Hello, and welcome to tonight's Human Papillomavirus webinar, a 2024 update. My name is Andrew Minton. I work for the Immunisation Coalition, and it's my privilege tonight to be moderator for this evening's webinar. As you can see, we're starting at 6 on the dot, and I'm very keen to finish at 7 o'clock on the dot as well, just to respect everybody's time. Some of you may be still at work, and some of you may be at home. It is dinner time or close to, and I'm very conscious of family time, so I'll do our best to finish at 7 p.m. If we could just go on to the next slide, please. So just some formalities before I introduce tonight's guest speaker, Angela Newbound. So just the welcome to country. I'd like to acknowledge the traditional custodians of the various lands of which we work, and welcome any and all Aboriginal and Torres Strait Islander peoples that may be on this webinar tonight. I'd like to pay my respects, and on behalf of the Immunisation Coalition, to elders past, present, and future, as well as specifically to the Gadigal people of Sydney, where I am currently residing. I'd also like to celebrate the diversity of the Aboriginal people, the ongoing culture, and various connections to the animals, the lands and waters of Australia. So just a bit of housekeeping. You will know all this already. So we will present, or our guest speaker will present for 40 minutes, which will allow us 15 minutes for Q&A. I do encourage you to ask questions. If you are, a watcher and a listener and an absorber, still, if you want to ask a question and it's your first time asking a question, why don't you just put a little abbreviation of HAG in the beginning of your question, and I know that it will be a first time have a go question. So I will do my best to look for these and raise this question during the Q&A session. This webinar is recorded, so all participants will be on mute, and the recording will be available as well as the PowerPoint on our website this time next week for your access under events and webinars, which you can easily find on our website. So with that said, I'd now like to introduce our guest speaker. For some of you, it's no surprise. I'd like to introduce Angela Newbound. I've known Angela now for a little while, and she's a regular speaker at many events, some of which are ours and some of which are others. But just to go through a little bio of Angela. Angela Newbound is a nurse. She's based in South Australia. She's an immunisation education consultant, also a member of the Immunisation Coalition, has been for some time, and has been involved in immunisation program delivery in South Australia for over 20 years. Angela provides clinical advice and some really good practical advice, and I saw that in last month's IC 25th annual scientific meeting, support and education to a wide range of immunisation provider, and contributes to the development of immunisation resources to assist providers with challenging aspects of the immunisation program. Angela is passionate about the role that nurses play in vaccinating against infectious diseases, and presents regularly, as I said, at IC events and non-IC events to a mixed healthcare professional audience. So I think I'm going to hand over to Angela. I believe we're going to start with a poll, but looking forward to your presentation tonight, Angela. Thank you.
Thank you very much for a very, very kind introduction, Andrew. Now that you know a little bit about me, I'd like to know a little bit about you. So here's our first poll. I'd love to know who we have watching the webinar tonight. So I'll give you a minute to fill that out. How did we go, Joanna? Have we got any results, or are they still polling?
I think that we can now share the results.
Lovely. Oh, fantastic. Oh, very good. So 78%, we've got nurses, midwives, immunisation practitioners, fantastic. And we've got some GPs and some pharmacists, and we've got a few other outliers as well, which is fantastic. So thank you very much. Look, I'd really like to thank the Immunisation Coalition, wonderful organisation, for inviting me to speak tonight on HPV. And as Andrew said, I'm from South Australia, and so I'm sitting on the beautiful Ghana lands here in Adelaide. So very privileged. So obviously, you know, with all the learning that we do, we have some learning objectives that we'll just each read there by ourselves, and we should be able to get through all of these tonight. I'm going to talk really quite quickly, probably, just so in the interest of time we get through and you've got the opportunity to ask some questions. Some of the information that I'll give you tonight you're probably well aware of, but I think, you know, for the newer providers that might be joining in, we'll just do a little bit of a recap really to what is human papillomavirus, or HPV. So we know that it's a really common infection. Probably about 90% of the general population will be infected with at least one genital type of HPV at some time in their lives. And people with persistent HPV infections really are at risk of developing HPV-associated cancers. And the most common, of course, is cervical cancer. And because the virus is just so common, HPV is actually often referred to as the common cold of sexual activity. And like any other viruses, we can be infected, but generally our bodies will clear that infection. So a lot of our HPVs are not cancer causing, and some of them just cause the old common warts. And they are really quite benign growths that form in certain types of tissues, and which can occur anywhere in the body. They can form on the skin, surface of the moist tissue linings inside the body, such as the gut and the airway, which we'll talk about a little bit later. So, like I said, the immune system generally clears this HPV infection from your body within around about a year or two. But sometimes these HPV infections are not so successfully cleared by your immune system. And there's about 3 to 10% of high-risk HPV infections where the virus does persist for many years. And that can lead to either moderate dysplasia or high-grade dysplasia that, of course, if untreated, might get worse over time and become precancerous, and then cancerous, although not all precancers will go on to become cancer. Research generally tells us that it can take around about 5 to 10 years for a HPV-infected cervical cell to develop into a precancer, and about, you know, even up to 20 years to develop into a cancer. So it's a little bit of a tricky virus if it does hang around. But there is a range of types of cancers that HPV can be responsible for, and certainly genital warts are caused by infection with, you know, HPV, mainly the types 6 and 11. And this infection is obviously diagnosed when you see somebody coming in with a wart on physical examination. The HPVs, you know, certainly can cause the majority of cervical cancer cases, and responsible for many of the oropharyngeal cancers and the anogenital cancers. And that is particularly in relation to types 16 and 18. And as we are aware, there are HPV tests that can screen for cervical cancer, but there really are no approved HPV tests to find HPV in these other parts of the body, which, you know, really can be problematic. So it's a really common virus, as we've said, and there are over probably 100 different types of HPV. But as you can see, around 40 types affect the anogenital area. So these types can be, are really high risk because they can cause the cancers that we want to try and avoid. Obviously, like I said, the most oncogenic HPV types are types 16 and 18, but definitely type 16. And that tends to be, the one that causes most HPV-related cancers. Obviously, cervical cancer remains a really major public health concern, but these other cancers of the anus, the penis, the vulva, the vagina, they are relatively uncommon cancers, but are thought to be increasing in incidence, and that may well be due to just increasing HPV transmission secondary to changes in sexual behaviours. Those low-risk types, like we said, such as type 6 and 11, are really associated with those non-malignant lesions, such as your genital warts. So HPV itself requires a breach in the epithelial surface to enter the basal epithelial cells and cause infection. However, it really does depend on what layer this infection becomes. So evidence really suggests that HPVs progress very, very successfully because it doesn't induce that immune system response for most of its life cycle. So the infection can be really remain quite uncontrolled and unrecognised by our immune system. And there's a whole reason for that. It's around about the keratinocytes, the target cells for HPV are really less likely to incite a really novel T cell response than other types of host cells. HPV produces genes that suppress part of the human immune system. The immune system, does have better detection, I suppose, in the lower layers of the epithelium, but really sometimes it's just not detected at all. HPV infection too doesn't involve the bloodstream, which means the mechanisms for the immune system to detect an infection are quite limited. And really, and finally, a HPV infection does not cause host cells to lyse or die, which would typically induce danger signals to our immune system. So it can be a little bit sneaky. So we know the incubation period, which is the time from someone becoming infected and developing symptoms, is around about 2 to 3 months, with a range of anywhere from 1 to 20 months for genital warts. And the infectious period, which is the time that somebody can actually be infected and to infect other people, for HPV really is unknown, but for genital warts, it's probably for at least as long as a visible wart exists. Often HPV infection doesn't cause any noticeable symptoms or health problems. Once again, quite sneaky, but visible infections when you actually see warts in the genitals, and they can look different in individual people and appear on different parts of the body. Like I said, they can be flat or they can be raised, they can be single or they can be multiple. They often can cause these little clusters or form these little clusters which look like a little bit like cauliflowers. Subclinical infection is when there's no signs or symptoms, but HPV is found inside the skin cells. And that means people can still spread it to other people. There's no known at this stage currently approved screening test for HPV in men. So if a man is concerned or has any questions, they should really be speaking to you, their health professional, go and see their doctor, the medical practitioner. And currently, there's really no cure for HPV, but and so to manage the genital warts, really, it is just ongoing treatments, really. But like I said, most people will clear these HPV infections over time. So these are our high-risk HPVs. Like I said, type 16 and 18 are the most problematic. They take longer to clear from the body. And certainly in some individuals, this HPV, infection remains for a really long time. So then you've got those significant cell changes. So that's that dysplasia, which really can progress into invasive cancer if it's not detected and treated at the early stages. It is rare for HPV infection to lead to cervical cancer, but if it does, it usually can take up to 10 years or more. In December 2017, just as a reminder, the cervical screening test replaced the Pap test in screening for cervical cancer. And the Pap test used to look for cell changes in the cervix. The cervical screening test looks for HPV, which can lead to cell changes in the cervix. So cervical screening, absolutely highly recommended every 5 years, whether you've been vaccinated or not. And they've really shown to be very successful for that early diagnosis and treatment. So at the point where abnormal cells are seen in the cervix, then they bind together, they form tubules, and cervical cancer symptoms might be apparent. And these are the most common types of signs that a woman may experience. And that's that vaginal bleeding that occurs in between menstrual periods or after menopause. You've got vaginal discharge that isn't right, might be tinged with blood. And there's just a whole range of different signs. And so quite often, these signs and symptoms can take a while. They don't get all of them. They might get only some of them. They may require quite a few GP visits to really diagnose what is actually going on. So how is it spread? The most commonly, it's transferred from person to person during vaginal or anal sex. However, penetrative sex is not the only way that HPV is transmitted. It can also be transmitted through just skin-to-skin contact, during oral sex or other types of sexual activities. A person with HPV can certainly pass that infection on to someone even when they actually have no signs or symptoms themselves. Anyone who is sexually active can get HPVs, even if they have had sex with only one person. But the risk of acquiring a HPV infection does increase with the number of sexual partners an individual does have. So I talked a little bit earlier about warts that can form in the respiratory tract, and recurrent respiratory papillomatosis can occur at different stages of life. And the juvenile onset form of recurrent respiratory papillomatosis affects children at the average age of about 4 years. And it's thought to be caused by transmission of the HPV virus from the mother to the baby during childbirth. And the risk of developing the disease is increased if the mother has genital warts present during delivery, of course, in younger mothers and in firstborn children. However, it is a rare disease. Even if a mother does have active genital warts, the risk of the child developing this recurrent respiratory papillomatosis is really low, around about 1 in 300 babies. So delivery by caesarean section doesn't always protect the child against that transmission of the virus either. So when a papilloma or a group of papillomas grow in the larynx, it can obstruct the process of breathing, and therefore the infant requires frequent laser surgery to prevent the warts from blocking its breathing passages. Unfortunately, papillomas may return after treatment or transform into a malignant tumour. So because of this, it might be necessary to treat recurrent respiratory papillomatosis multiple times. Symptoms of respiratory papillomatosis include hoarseness, a quiet or a weak cry, an airway obstruction, obviously very severe and needs to be dealt with very, very quickly. So HPV, obviously we've already made the statement that if you're sexually active, you know, most people will acquire a HPV at some time in their life, particularly if they are not vaccinated. In 2018, La Trobe University in Melbourne surveyed just over 6,000 secondary school students in years 10 to 12 from across Australia, and found that 47% of students have had sex, defined as vaginal and or anal intercourse, regardless of the gender of the partner. Year 10s were much less likely to have had sex yet. 34% had, compared to the year 11s at 46% and the year 12s at 56%. So the average age for that 40% who have experienced sexual intercourse in the survey was about 16 years of age. So if you are a parent of a teenager, you must be absolutely shuddering at that particular statistic. So lots of factors. Biological-based risk factors would be this list here. So the high rate really of HPV prevalence amongst HIV-infected women is thought to be due really to that compromised immune system. And that compromised immune system for these individuals really enables that viral persistence of HPV and increasing that probability of contracting infections from multiple HPV genotypes. So obviously, with those high risk genotypes, then that's a high risk for cervical cancer. The age of first sexual intercourse in some studies has not been related to HPV risk, but in other studies it is associated with HPV prevalence. Some studies have suggested that older age of first sexual intercourse was a risk factor for high-risk HPV infection. So we definitely need to consider all of these biological factors. We then have behavioural factors as well. And those really have been looked at in a multiple number of studies, and they have examined the risk factors for genital HPV infection, particularly with these high-risk types and these lifetime number of sexual partners, having a new partner, the partner's sexual history is of interest. High-risk sexual behaviour is the main risk factor associated with the acquisition and persistence of HPV infection and that development into a HPV-associated cancer. Studies have also demonstrated that cigarette smoking is also associated with HPV load. The prevalence of HPV, the incidence and the persistence. And this may be because ingredients of cigarette smoke have also been shown to modify the function of immune cells. So if we're looking at the different types of cancer, you can see in the males and the females, and this is the crude rate per 100,000 men or 100,000 women per year. And the HPV and related diseases summary report in 2022 stated that around 41% of oropharyngeal cancers, which mainly compromises the tonsils and the base of the tongue sites, reported in Australia were caused by HPV. And once again, HPV type 16 being the most frequent type. Globally, in 2020, there were around about 600,000 new cases of cervical cancer and about 340,000 deaths. Australia has one of the world's lowest rates of cervical cancer mortality, which is fantastic. But in saying that, 328 deaths is too many. And according to Cancer Australia in 2021, it's estimated that a female has about a 1 in 663 risk of dying from cervical cancer by the age of 85. It's certainly one of the most preventable and treatable forms of cancer, but that continued participation in the National Cervical Screening Program, as well as vaccination of boys and girls against HPV through the National HPV Immunisation Program, is absolutely vital to ensure the elimination of cervical cancer as a public health problem can be achieved. As we previously highlighted, we know that there are many types of HPV that can cause cervical cancer, but as you can clearly see on this table, type 16 and 18 are the most common causes. And around about 8.5% of women in the general population are estimated to harbour cervical HPV 16 or 18 infection at any one given time. So, looking at HPV prevention is always better than the cure. And these are the current vaccine dose recommendations for immunocompetent individuals. It's just a single dose of HPV vaccine now that's recommended as part of the National Immunisation Program for boys and girls. And generally, it's given in year 7 in a school-based immunisation program. But if anyone has not had their dose of HPV vaccine, or Gardasil is what we're using in the school program, they are eligible to receive one free funded dose up to 25 years of age. So there was a change in the dosing. Some of us that have been around the immunisation program for a long time, we know that in 2007, when we started vaccinating against HPV, it was a 3-dose schedule, then went to a 2-dose schedule, and now there is only a single dose. And it's really because there's been multiple studies that have found a single dose of the 9-valent HPV vaccine, so that's your Gardasil 9, provides similar protection against HPV 16 and 18 as a 2-dose or a 3-dose schedule. And ATAGI, the Australian Technical Advisory Group on Immunisation, their recommendation aligns with those of the World Health Organisation, Strategic Advisory Group of experts on immunisation, as well as the United Kingdom's Joint Committee on Vaccination and Immunisation. And the Pharmaceutical Benefits Advisory Committee, or the PBAC here in Australia, has endorsed ATAGI's recommendations to bring it to a 1-dose schedule. However, while a single dose is recommended for immune-competent individuals from 9 years of age up to their 26th birthday, a 3-dose schedule is still recommended for all immunocompromised individuals, regardless of age, and any person aged 26 years and older. So if an older person after 26 years of age is starting their vaccine program, they would be started on a 3-dose schedule. So we've got a poll for you. This might just start the brains working a little bit. So what is the minimum acceptable interval in a 3-dose HPV vaccine dose schedule? Is it 3 weeks between dose 1 and 2 and then 16 weeks between dose 2 and 3? Is it 4 weeks between dose 1 and 2 and 20 weeks between dose 2 and 3? Is it 3 weeks between dose 1 and 2 and 16 weeks between 2 and 3? Is it 4 weeks between dose 1 and 2 and 12 weeks between dose 2 and 3? Now, remember, we're talking about the minimum interval. So we'll give you a few minutes to think about that. Depends on how quick you are about Googling the immunisation handbook. Okay, how are we going, Joanna? We got any answers yet? And how did we go? Oh, very good. We've got a bit of a smattering across all of the 4 answers. Well, the 56% that said it was D, the answer is D, were correct. So bear in mind, this is the minimum interval between doses. The recommended interval between the doses is 2 months between doses 1 and 2 and 4 months between dose 2 and 3. So well done for everyone that answered D in that poll. Okay, so who else should be vaccinated then? So studies have really demonstrated that men that have sex with men are more commonly affected with multiple HPV genotypes and can take longer to clear the virus infection. They've also got significantly higher incidence of high-grade anal cancers as well than the average population. And overseas studies have really found a greater than 30-fold higher incidence of anal cancers in men that have sex with men versus other men. So definitely adults aged 26 years and older who have been diagnosed with or have had a history of HPV-related precancerous or cancerous lesions might need to be considered for vaccination because of their inability to clear and control HPV infection, noting that vaccination protects against future infections and does not have therapeutic benefits for an infection that is already existing. Chronic immunosuppression for various reasons is an important risk factor also for persistent infections with HPV and HPV-associated disease. And that's really because the immune response is likely to be lower in immunocompromised people than in healthy people, hence the 3-dose schedule recommendations. And those immune compromising conditions really are those primary or secondary immunodeficiencies. So that's complete or partial deficiencies of B lymphocyte antibody or T lymphocytes, HIV infection, malignancy, organ transplantation, or if they're on significant immunosuppressive therapy. People with asplenia or hyposplenia, so they may not have a spleen or they may have a spleen, but it just doesn't work properly. They're actually only recommended to receive just the single dose schedule as per an immune competent individual if they met that age requirement of 9 years to 20 up to their 26th birthday. So this is now bringing us to our second poll, and it's talking about that vaccination for adults that are 26 years and older. And is the vaccination actually routinely recommended? So answer could be no, as they are likely to have had been exposed to one or more HPV types through sexual activity, or B, yes, all adults should be routinely vaccinated with a HPV vaccine, or C, no routine vaccination should be started at 17 years of age, or D, yes, adults can be given an oral dose or an intramuscular dose of HPV. So let's see what the answers might be. We'll give you a minute. Okay, how did we go, Joanna? We got some answers?
Well, we do have 120, no, 210 now. Oh, wow. Yeah.
Well done.
Okay, I think that we can go now.
Sure. Oh, once again, a little bit of a smattering across, but that 59% that said A is the correct answer. So many adults are likely to have been exposed to one or more HPV types contained in the vaccine through sexual activity. And vaccination is not going to clear that past or current infection, but it can provide protection against future infections from other types contained in the vaccine. So while not routinely recommended, Gardasil 9 vaccine is actually registered for the use in females and males right up to 46 years of age. So just also note that all men who have sex with men, including those aged over 26 years, are recommended to receive HPV vaccination, vaccination. Okay, so there are two types. We have Gardasil 9, which is the 9-valent. It's free in the school program. It's the one that's registered for males and females. There is another brand of vaccine on the private market. It's only a 2-valent, so it only has the 2 serotypes. It's called Cervarix. It's only registered for females aged 10 to 45 because it really the only 2 serotypes in the vaccine are types 16 and 18, which cause the majority of cervical cancers, which this program was originally designed mostly to reduce those numbers of cervical cancer cases. So Cervarix, like I said, 16 and 18, only the 2 types, whereas Gardasil 9 we have been using since 2007 when our program started here, and it's providing exceptionally good cover, and we are certainly seeing the results of this program. So all Year 7 students are offered this vaccine. However, vaccine uptake really is less than optimal. By the end of 2022, there was only around about 80% of females and about 76% of males assessed at 15 years of age by the Australian Immunisation Register to have received the recommended doses of Gardasil 9 vaccine. Now, with the change to a single dose, we're hoping that once we do see some later data that we hopefully will see a higher uptake, but we are struggling a bit in our school immunisation program with coverage. So put your thinking caps on about how you may be able to contribute to increasing that vaccine coverage. So obviously there's some people who can't receive HPV vaccine, and that's anyone that's had an anaphylactic reaction to the vaccine or a component of the vaccine. And we don't routinely vaccinate pregnant women against HPV, that's for sure, and clinical trials and limited data from observational studies where HPV vaccine was inadvertently given during pregnancy have really indicated that there's no increased risk of adverse effects on the fetus. However, it's just a vaccine that we wouldn't be giving in pregnancy. But if a woman does become pregnant during the course of HPV vaccination, we would probably just recommend that we stop the program for that particular woman until after she has delivered her baby. So, but most other people should be able to receive this. So this is our third poll now, and when can women who wish to conceive following a course of HPV vaccine commence trying to fall pregnant? So it could be A, immediately after their last dose of the vaccine is not a live virus, they've got to wait for 4 weeks, or C, is it 1 week after their last dose, or D, immediately after their last dose of the vaccine is not a live virus but won't affect the fetus. The vaccine is a live virus, so it won't affect the fetus. So A, B, C, or D? Okay, what are our thoughts, Joanna? Are they still
we
polling?
are, yeah, yep. Okay, seems to have, okay, let's finish now.
Okay, so once again, a little bit of a smattering right across, but that 52% of people were correct that polled A as their answer, because the vaccine is not a live virus vaccine. So therefore, women would not need to defer conception if they wanted to go ahead and get pregnant. They are more than welcome to just go ahead and try for a pregnancy as soon as they've had their last dose of vaccine. Absolutely. So we talked a little bit before about cervical screening, and certainly despite advances with the HPV vaccine, it really is still essential that individuals aged between that 25 and 74 who have a cervix and who have been sexually active at any stage should continue to have a cervical screening test. Anyone eligible for cervical screening tests has the choice now to how they screen. They can either do that through self-collection of a vaginal sample using a simple swab, unless a co-test is required, or the clinician. You can go and see a clinician and have a collection done, which is a sample from the cervix using a swab and a speculum. The self-sampling HPV test has really been proven worldwide to be accurate for HPV detection, and that it can increase coverage for cervical cancer screening in the national program because it is easy to use, it's convenient, it's a lot less painful because there's no speculum involved, it's less embarrassing for women, they don't have to lay on the couch and expose themselves to a clinician. So, but it just seems that maybe self-collection has not been offered to as many patients as what we would like to see. So if you are a provider in general practice, please keep in mind that this self-collection is a great way for women to be able to just go ahead, and it is showing to be really accurate as well. So please think of offering it to any of the people that are eligible for cervical screening tests. So we found that the program is preventing cervical precancer lesions in young women, and this was published for the first time as part of a collaborative study between the Australian Institute of Health and Welfare and the Victorian Cytology Service. And the study found that women vaccinated with all of the 3 doses at the time of the school cohorts and the catch-up program of a 48% lower rate of the most serious precancerous abnormalities than the unvaccinated women. So this is a really successful vaccination program, but like I said, our coverage is a little bit suboptimal, and we would really encourage you to have these conversations with any student or parent of a student that may have concerns about the vaccine. And according to Cancer Council New South Wales, within the first 4 to 5 years after the vaccine program commenced, precancerous abnormalities decreased by 34% in the 20 to 24-year-olds alone, which means that they will be at much lower lifetime risk of ever developing cervical cancer. So it's a great program. We just need to get this vaccine in these people's arms. You know, we can have the best vaccines in the world, but they are absolutely useless if they're just sitting on the shelf in your fridge. They need to be put into people's arms in order to make a difference. So looking at that vaccine effectiveness of that single dose, there's multiple studies done. The first randomised controlled trial of a single dose of HPV vaccine efficacy was undertaken in Kenya, and the trial showed greater than 97% efficacy against persistent HPV 16 and 18 infection at the 36-month mark among women in Kenya. And so those successful long-term HPV single-dose studies have also been undertaken in Costa Rica and India. HPV vaccines are really highly immunogenic, and a clinical trial showed that the efficacy of a single dose of the 9-valent vaccine against persistent HPV infection, like I said, was really high, so 97.5% in young women aged 15 to 20 years. It is currently unknown if immunity following HPV vaccination is lifelong. Obviously, observational studies have demonstrated that that single dose of HPV vaccine provides protection up to about 11 years after vaccination. Immunogenicity stabilises 12 months after vaccination and does not appear to wane thereafter. So we just wait and see what the data is going to tell us with the real long-term research that's done on all of our vaccines, and particularly on this single dose. So, we've definitely got to increase vaccine uptake. We've got to continue with our ongoing cervical screening program, and we are really hopeful that this is a disease that we can actually eliminate. So cervical high-grade abnormality incidence rates also decreased in vaccine-eligible age groups by 48%, like I said, and 20% in females of 20 years and those aged 20 to 24 years, respectively. And data linkage studies have also shown that fully vaccinated females in 2007 through to 2014 had lower grades of high-grade compared to the unvaccinated females at the same age. In 2022, there were, certainly 222 deaths of women with cervical cancer in Australia, which accounts for 1% of all female deaths from any cancer at all. So, safe, well-tolerated vaccine. Typical adverse events as any other vaccine, with that pain, redness, swelling around the injection site, with a bit of a fever, some get a bit of headache and some nausea. So pretty well tolerated vaccine. It does sting a bit, this Gardasil 9 vaccine, but realistically, a single dose now hopefully is not going to worry too many people having it. There's obviously been a lot of media that's negative around vaccines, and it doesn't matter which vaccine it is, whether it's COVID vaccines, flu vaccines, HPV vaccines have not escaped it. And there's a lot of controversy, particularly around social media and in certain populations, but there have been absolutely no studies that have shown that there's an impact on human fertility following HPV vaccines. And some websites report really disturbing claims that one of the ingredients of the vaccine, which is polysorbate 80, causes infertility in rats. And this was really based on one study of newborn rats that weighed only 10 to 17 grams, and they were given an extremely large dose, 20 to 200 times the amount of Gardasil when it was injected into their little abdomens. So there was a big campaign, and I remember here in South Australia there were little notices going in under everybody's windscreen wipers in the car park saying, you know, this vaccine causes infertility, don't give it to your girls. And really it was just taking that little tiny snippet of information out of this study to say that it caused infertility. They just didn't allude to the fact that it was in little baby newborn rats that weighed that tiny little amount of grams. But the TGA, of course, have reviewed all of the available data and really concluded that there's no evidence the amount of polysorbate 80 in HPV vaccines poses any risk to human reproduction or fertility. And we've just got to remember that polysorbate 80 is a really, really common product, not only in medications and other vaccines, but it's also used in food as a food additive. It's also in cosmetics. And if you really want to be sure that it's actually quite safe, polysorbate 80 is the agent that's most commonly used by the ice cream industry for destabilization of the fat emulsions, making the ice cream a lot smoother and easier to handle, as well as increasing its resistance to just melt as soon as you get it out of the freezer. So if you enjoy your ice cream, you're enjoying some polysorbate 80, and it's really quite safe. Of course, there's always controversy around aluminium, and as we know, adjuvants are used in vaccines to enhance the ability to really provoke a robust immune response. And, you know, that we really do know that aluminium is one of the most abundant natural elements on the earth. Aluminium does seem to have an impact on their immune system, which is why we use it in vaccines. And it has really rendered it very, very useful in the vaccine industry as an adjuvant. It stimulates those Th2 type responses and antibody production through those B cells getting activated, activating the complement system, and by recruiting those immune cells to the site of injection. And once again, analysis of several clinical trials involving more than 20,000 participants found that the overall proportion of participants who reported new onset autoimmune conditions was very, very similar amongst those who got the vaccine and those who got a placebo. So it is safe to use in the way that it's used with vaccine production. So autoimmune diseases also, POF, also known as premature menopause, has long been known to occur in females who have not been vaccinated. And there's absolutely no evidence of an increase in POF in HPV vaccinated females, or any proof of a link to the vaccine at all. So complex regional pain syndrome and postural orthostatic tachycardia syndrome, or POTS, are both conditions thought to be caused by a variety of known and unknown factors, and are diagnostically challenging, with onsets really difficult to determine and symptoms that often overlap with other conditions. There's no evidence at all to support HPV vaccine as a particular trigger of the complex regional pain syndrome, more than that rarely seen for any other painful stimuli. And similarly with POTS, occurs irrespective of vaccination, and preclinical and clinical studies have found no evidence on or basis to suggest a causative relationship between POTS and HPV vaccination. So hopefully that information can, certainly help you with your discussions with individuals if they've got some concerns about the safety of this vaccine. So very quickly, just to conclude, genital HPV, very, very common, both in females and males. We know that there are some high-risk HPVs, and particularly types 16 and 18, that are, quite oncogenic. We know that it's a single dose now for boys and girls, and it's free in the school program for Year 7 students, as well as anyone that's missed out on receiving a dose of HPV vaccine up until their 26th birthday. We know that these vaccines are safe and well tolerated, and we know that vaccination does not prevent infection from all of those, all HPV types, because there's so many of them. And so we've got to use those other strategies such as cervical screening, and just making sure that all these doses are reported to the AIR. If it's an NIP-funded vaccine, then it's absolutely mandatory that you report them. But all of your practice software should be just reporting any vaccine that you're giving in this day and age, really. So thank you for listening, and I hope we've got some time for questions.
Thanks, Angela. Really great overview. We only have 4 minutes.
Oh, goodness, sorry.
And we have 23 questions. So as I said, if we don't get to the questions, we will provide written answers and we will communicate with everybody on the webinar. But I do have a number of them, so let's see if we can rapid fire them.
Yes.
In no particular order, but we do have a go question, but I'll get to that in a minute.
Good. Yeah.
Is Gardasil 9 or Cervarix free for older women that has multiple myeloma? She's stable now. Do we give her 3 doses, and does she pay, or is it government funded?
Yes, not free. It is not government funded at all. She would need to pay for it. So if you felt that there's clinical benefit there, then yes, she would need a private prescription.
Okay, thank you. Is a 3-dose schedule for immunocompromised people well, free for all ages? We know it's not, but
yeah, correct. Yes.
Okay. From David, stem cell transplant patient, any age, 1 dose or 3 doses?
So I would be thinking that they would be on quite significant agents. So I would always be very careful around patients with severe immune compromise anyway, and particularly patients like hematopoietic stem cell transplant patients, because I think clinicians should be working really closely with the hematologist that's looking after that patient. And it's the same with anyone with any other forms of cancer, working with the oncologists that are with those patients as well to find out what's the best course of action for them.
Thank you. How long since HPV exposure until CST will detect it?
Good question. I don't know. There may be somebody that's online that will know. So if you pick up a HPV infection yesterday, will it be detected on a test tomorrow? I don't know. I'm not even going to hazard a guess on how quickly it would show up on the test, but we can get back to that person for sure.
Yes. Okay. Thanks. From Christine, is vaccine needed in celibate people, those that are not sexually active? Doesn't say an age, but younger, I guess.
Correct. So if they have had no sexual activity, so just remember, it doesn't have to be penetrative sex, all right? It doesn't have to be penetrative intercourse. So it would depend really how celibate is celibate.
Okay. This is from Pam. New question. Haven't asked a question before. How do you know which type of HPV you have? That will come down to test result. Is the 16 to 18 type more troublesome, which you have answered actually?
Yeah, absolutely. And it's up to the laboratory to sequence the HPV type on your test. Yeah.
This is from Sharon. If the highest prevalence is 18 to 25, why is the recommended age for starting CST 25?
Yes, I don't know why they have drawn that line in the sand, to be really quite honest. I suppose they've had to look at the time frame that it takes for these HPVs to develop into a cancer. So I don't know the full answer completely, but we can certainly get back to that one as well.
Sorry, I've put
Just
you
put
on.
a notation next to that one, Andrew, so I remember.
I have, yep. Why does AIR not show the Gardasil 9 as due until they are 14 years of age and overdue when they're 14 and a half, when actually the schedule is due from 12 to 13 years of age?
Yeah. So look, the due and overdue rules with AIR are really very different from vaccine to vaccine, because we give these people plenty of opportunity to catch up on a missed dose. They are not assessed as fully vaccinated until they're 15 years of age. So once again, I dare say lines have been drawn in the sand, and that's how they do it.
Okay, we just have time for one more question, so it's 1 minute before 7, according to my clock, which is 1 minute slow. Long-time partner, don't know the age. Suspected infidelity is an interesting question. Previous screen showed no infection. Should I continue with my cervical screening?
100,000% yes. Continue with your cervical screening, absolutely. Whenever it is due, definitely. Even if your husband there was no infidelity, you should still be going for your routine screening when it's due, for sure.
Okay. All right, I think I'm going to have to wrap it up. I did say 7 o'clock, so we'll try and keep to time. So again, thank you, Angela. Wonderful presentation. And
Thank
also
you.
thank you to the audience for your engagement. And there's been a lot of questions. There's been 28 questions. I'm sorry I didn't get through to all of them. I just draw your attention to the next webinar, also with Angela and myself. It's on influenza. That's on the 3rd of April. That will be communicated. You can register on our website now, but also be communicated in our monthly newsletter, a Monday newsletter, which comes out obviously every Monday. There is a future webinar which is not on our website at the moment. It's going to be a very interesting one. It's going to run for 3 months. It's a webinar series. It's covering flu, COVID-19, RSV together in the same webinar. There will be specialists on that webinar. It'll be a discussion forum, so there will be no slides. It will be a discussion forum, but there will be pharmacists there from the Guild, from PSA, and another. There will be academics there from the WHO. There'll be a nurse. As I said, there was a pharmacist, and there'll be a pediatrician and respiratory physician. So it's going to be a very exciting panel discussion forum on these 3 infectious diseases every month, starting from the 17th of April. So do look for that in about 2 weeks' time. There'll be a short survey. If you could fill that out, that would be much appreciated. So thank you for your time. Look forward to seeing you on the 3rd of April. We've kept to time. I would just wish you well, stay safe, and good night.
Thank you very much. Good night, everyone.